we actually have 3 people who are going to speak today. I'm just making a few comments right now, and then I'm going to shut off my microphone and my camera. We're going to be hearing from Lee Steele, who is our family advisor here at the Azrieli Center. And actually was one of the people who thought it was really important for us to cover this topic. So I'm so grateful, Lee, that you brought that up for us. And we'll be listening to Audrey Cole, who's on the telephone. And Audrey is really a pioneer when it comes to community living and community supports for people with developmental disabilities here in Ontario, and I would say across Canada. And Audrey's going to make some really important reflections around issues when it comes to decision-making and supported decision-making, and kind of what that means and why it's so important when it comes to healthcare for your loved one with a developmental disability. And then we'll be hearing from the healthcare provider side from Bill Sullivan, who's a family physician and an associate professor at the University of Toronto. And he's also, for those of you who don't know, we've talked a lot over the last several months about a number of sort of guidelines and tools that we talk about. These are the primary care guidelines for adults with developmental disabilities that are used across Canada and actually referred to across the world. And Bill really was the lead behind getting those guidelines started and developing all the various tools in that entire program. So one of his areas of interest is also the issue around healthcare decision making and planning around healthcare decisions. So we're lucky to have him join the conversation as well today. So, so Lee, I think the next person to be speaking, are we going to be hearing from Audrey next?
Yes.
Okay, perfect. So I'm going to turn my camera off and really excited to listen to Audrey Cole. Thank you so much.
Right now?
Yeah.
Okay. So my name is Audrey Cole. My almost 56-year-old son, Ian Cole, is a man with a severe intellectual disability. When he was born, minimal government support for children with intellectual disabilities. They had no rights. Segregation and discrimination were the norm. The best we got were charismatic community nurses who knew lots about babies, but nothing about disability. Ian was 15 before he was even allowed into the school system, and then only in the segregated class of 5 children of varying ages who had no speech. Needless to say,
do you want to try logging out and logging back in or something? I don't know.
Most of my voluntary effort since Ian was born has been human rights activism in and around the Canadian Association for Community Living at all its levels. It became a passion for me in the mid-70s when I realized that the new proposed Canadian Human Rights Act didn't include intellectual disability as a prohibited ground for discrimination. And I was shocked. I immediately wrote letters and resolutions and alerted the association, and it took us 5 years to get the legislation changed. In the meantime, we had the new Charter of Rights and Freedoms, but in that case, the government did listen to our arguments and did recognise disability. So why do I mention all this? Because life for people with disabilities is an everlasting battle to be included. Why has the community living movement and its allies had to spend hundreds of thousands of hard-sought dollars and hundreds of thousands of hours in court cases on all of these matters? We have to face it. Society at large does not include people with disabilities. When government lawyers write legislation, they never give a thought to the particular implications for that minority group. It does not have a respected identity. That's why we have to spend so much effort fighting for changes to current law. We have to get to a point where the realities faced by our family members are automatically included in legal and social considerations. Why is it so important? Did you realize that the only people in the province that have to prove that they can make decisions independently without help are people with intellectual, developmental, or mental health disabilities, and elderly people whose cognitive capacity is diminishing? No one else wants to prove that they can make decisions independently. The rest of us, most Canadians, are free to
I think that there's a special,
making decisions.
one time I used Java, and I should have just stayed
That sounds fair. Not to me. It sounds to me like discrimination, and that's what it is.
As long as I can see where the slides are.
I'm sorry? I didn't hear that. What can we do about it? Canada has agreed to international law that could fix the problem. But although Ontario signed on to that agreement, it does nothing to make it happen. 10 years ago, Canada ratified the UN Convention on the Rights of Persons with Disabilities. That means that Canada has agreed that persons with disabilities are equal citizens, unlike the rest of us are presumed to have legal capacity. In defining what that means, the Office of the United Nations High Commissioner of Human Rights is very, very clear. The office says having power to make, that legal capacity means having power to make, modify, and terminate legal relationships. And doing so doesn't necessarily require having the cognitive abilities on one's own to understand and retain information and appreciate consequences. A person's unique abilities can be enhanced with decision-making accommodations by other parties and also by assistance from decision-making supporters who can assist in interpreting and translating a person's will and preferences in the making of particular decisions. That means that all Canadian citizens, without exception, have a right to supported decision-making. Yet some provinces, such as Ontario, are not fulfilling the obligations required by that. In Canadian society, in my opinion, we have this strange tendency to see guardianship as beneficent. On the contrary, if we really stop to think about it, guardianship deprives those subjected to it of the fundamental right to equality. Supported decision-making addresses the necessary issues without diminishing the legal and social status person. Most of us already benefit from supported decision-making without ever giving it a thought, but there's a significant minority of Canadians, including many of our sons and daughters, for whom access to all levels of supported decision-making are absolutely essential. We cannot stand by and allow our family members to be denied that right and forced into legal oblivion. We, of all people, have an inherent obligation, and we can do it. Thank you.
Thank you so much, Audrey. As a caregiver's listening into this session, I wish that the audio was crystal clear because, I mean, you are such a pioneer and you've done so much advocacy. And to be honest, even though my son is 28 years old, this isn't a topic I've actually given thought to, and that's why I thought it was really important that we have a lunch and learn to talk about different things that maybe we don't think about enough as parents because we're so busy in sort of the day-to-day challenges of supporting our loved one. And the topic that you were talking about, the difference between supported decision-making for our loved one and substitute decision-making, this wasn't even on my radar. And I'm so, so grateful of all of the years and thought and speaking out on this to policymakers and physicians and government to bring this to people's attention. And as the self-advocates like to say, you know, nothing about us without us. And certainly this idea of guardianship and substitute decision-making is something that all of us who have adult children need to learn more about and think more about and take action and stand behind you and the people that have gone before us, parents of maybe younger adults. So I'm so indebted to you. And as I said, I wish your words were coming in even clearer because you really speak about this passionately and eloquently. And I'd like to make sure that we put some of your written words into our resources so that people can read what you have to say because this is such an important topic. And I think that this is, you know, and I wanted to also have parents learn from Dr. Sullivan because I heard Dr. Sullivan speak on some of the tools that we can use as families, advanced care planning, and some tools that have come out since COVID, hospital transfer tools. And just as, Dr. Sullivan is also a big champion of the inherent right of the difference between what we have in Ontario now with the substitute decision-making versus full citizenship of supported decision-making. And I'm really grateful for both of you to be here today and inform us about these things. And I personally was thinking about, well, how come as an advocate and someone who supports families and, sort of been around like a lot of disability support groups and talks, why aren't we discussing this? And I think for me, I had to just speak personally that I think it's really hard to think about the future when I'm not here. And so I kind of push it to the back of my mind and think, oh, get to that later. And maybe as a result, I just have to confess, like I really don't know about these things that we're talking about today in the way that I would like to, and I'm going to be sort of rededicating myself to. So I'd just like to pass it to Dr. Sullivan now to teach us even more from his knowledge. And again, I'm so thankful, Dr. Sullivan, you're here and taking time away from your busy medical practice to inform us.
Can you hear me okay?
Yes.
we can.
Great. So I'll maybe just invite Irfan to open up my slides, and I'll just ask you to advance as I go through. The first slide was really just introducing myself. My name is Bill Sullivan, and I'm a family physician. I'm based at Surrey Place and St. Michael's Hospital. And I just also wanted to mention that I don't have any conflicts of interest for what we'll be talking about today. So just to get started on my part, which is about promoting decision-making capabilities, I just wanted to say that this requires a partnership. And the partnership is really partnering with the person with a disability. We call this patient-centered care. And there's two teams that would be partnering. One are the caregiving team. And so I think many people on this webinar would fit into this category. I also would include other supporters, particularly decision-making supporters. And then above is the healthcare team. And kind of to keep it simple, the primary care provider or family doctor, usually supported by a team, would be the kind of the access to other dimensions of both the health and the developmental services systems. So if you think of what we're talking about as something that involves this sort of team, we'll just go to the next slide. And this is just to show a template of what one might call a healthcare plan. This example is really just to illustrate the dimensions of what an integrated plan would look like, and to emphasize that all these boxes in this template require decisions. This is just an example that we've been using at St. Michael's Hospital with Surrey Place on a transition age youth clinic for people that are moving into adulthood. So all I wanted to highlight is first what I just said about the teams and the partnerships. It's that green shaded column of who's involved in the decision. And at the top is the person and caregivers. And then going across, it's just identifying different types of tasks. So what is it that needs to be done and when? So that's essentially what a plan involves: who, what, and when. And I've divided these tasks into three basic categories. And you might think of the first column as of health habits as the past. It's really the foundation of health. This is where nursing care has such an expertise of promoting good health habits. The middle column is the present. It's something new that might be happening, or there's some ongoing health condition that might need adjusting. And then the final column, preventing illness, is about the future. And so if you look at this basic integrated healthcare plan, and all the boxes are decisions that need to be made, and they're all in support of the person with the disability. So just move to the next slide, please. So why is it important to involve people in such healthcare planning? Well, I think that the more persons are involved in such decisions, the more likely they will be invested and participate in implementing the plan and taking over things that they can manage, including developing self-care skills and other good health habits. So next slide. So I guess I also wanted to point out that while it's important, it's also challenging. And what I wanted to just flag is this idea that many of you have probably heard called ableism. And this is just an effort to define what that is. And it's really talking about a certain bias that is found in healthcare and elsewhere that devalues and limits the capabilities of persons because of their intellectual or psychosocial impairments. It's a matter of not recognizing that people with intellectual and developmental disabilities can develop and hold goals and values to inform decision-making and planning, even if they might need some degree of support in understanding and applying them, as Audrey was saying. And ableism can be subtle, that in practice, it involves a kind of a taking over of decision-making, often not even recognized. And it's also felt to be for the good of the patient, or because this is the way it's always been done. And often without just assuming that the person with at the center of the decision-making either doesn't want to be involved or is just not able to participate. And often that assumption is incorrect. Next slide. This is a film that I would recommend that came out recently. It's called The Peanut Butter Falcon. That is an excellent illustration of ableism. If you haven't seen the film, the person in the background throwing something is Zach. He's a young man with Down syndrome who is the star of this film. This is just one scene where there's a bit of a confrontation between Zach and Eleanor, the nurse, whose back we see. Eleanor is a very caring nurse and very concerned about Zach's well-being. But in fact, at this scene, Zach is basically running away from a kind of a nursing home where he had been for several years, actually, to pursue his dream, which happened to be to become a wrestler. And in this scene, he's kind of throwing away the car keys, kind of communicating to Eleanor that he doesn't want to go back. But I think the scene, that this is just one scene, there's a more powerful scene a bit later where this becomes quite evident that this is a very well-intentioned act on Eleanor's part, but in fact is ableism, treating Zach as if he just can't make decisions himself or be supported in those decisions. So next slide. So these issues are, come up all throughout life, but in particular during times of transition. And so we can think about two life stage transitions. One is to adulthood, and the other is to retirement and older age. So I think that they most, for everybody, this is part of kind of the rite of passage into adulthood, is decision making and kind of recognizing the patients developing goals and values, and mentoring and training decision-making skills, and just making it possible in any area of life that people are involved and have practice in making all kinds of decisions. It's one of these things that, you know, we develop skills over time. And it's a little different as people become older, partly with failing cognition perhaps. It's others supporting them, recognizing past and present goals and values, who this person is, and helping to support decisions that are consistent with those. I've indicated just as a resource to clinics that are involved at these important times of transitions, and this is where these decision-making issues typically arise. Next slide. So I just wanted to distinguish between what is called a capability and what in the law they focus on, which is capacity. And typically, capacity in the law has to do with an ability to understand and appreciate independently. And so when we talk about capability, we're talking about those abilities, but also with support. And as Audrey said, all of us throughout our life draw on supports as needed to some degree for some decisions. So what we're talking about when we talk about promoting capability is promoting both these functions as well, but also with supports. So just next slide, please. So what are we talking about when we speak about the decision-making supports? So a lot of this is pretty basic, but surprisingly can be easily overlooked. So one is just paying attention to the environment, allowing sufficient time, making decisions possibly over several visits. What's the hurry often? Communicating effectively. There may be some training and mentoring that is needed. And finally, decision-making supporters that can help as needed with things like appreciating benefits, risks, and burdens of proposed treatments, eliciting goals and values, and applying these goals and values to the treatment options at issue. Next slide. So I think what the shift here is to try to begin to understand decision-making as involving a range of functions and a range of supports to enable people to actually meet capacity tests that are required in law. And so this is actually just a way of distinguishing between what the current approach is, which is the left column. Normally, when a capacity assessment is being done in healthcare, what is typically thought of is that this is something the person has to do independently to meet this capacity test of ability to understand and appreciate. The next column in the middle is what Audrey has been talking about, which I would call interdependent approach to decision-making, where the person can meet the capacity test with decision-making supports if offered. So it's still a person-centered approach, and it is the one that we're advocating for, especially when people have an intellectual disability. And this is actually often done in healthcare, but not formally. And so this was an attempt to formalize that. And so the last column, substituted decision-making, is when the person cannot meet the capacity test, even with available supports. Next slide. So I'll just close, actually, quickly by highlighting a couple practical tools that might be helpful to get started in thinking about how this might actually work. So this is just a tool that actually will be published in about a week. It took a lot of work with a few lawyers because this is actually very tricky ground to make sure that this approach to supporting people's decision-making meets the legal criteria in Ontario. So this is just an image to show what the website looks like. and where you can find this tool. Next slide. So what is this tool for? One of the things it helps is prior to a patient's visit, kind of guides caregivers through a process of seeking information from patients and caregivers for clinicians to plan needed adjustments during the assessment. So it may be that the environment needs to be adjusted, the way of communicating, the amount of time, et cetera. It also provides some information about a specific healthcare decision. So it helps the clinician, guides them through a capacity assessment. It's really what we're assessing is the capabilities of the person and the supports that are needed. So assessing the patient's need for one or more decision-making supporters, and that would put them into that middle column of interdependent decision-making, and gives the clinicians suggested questions for eliciting goals and values that are so crucial to making these decisions. Next slide. And this is one other practical tool that we have that is currently ready, and it is made in the context of COVID-19. And it talks about advanced care planning. So it's a guide for caregivers of adults with intellectual and developmental disabilities. So one thing that we realize is that a lot of people do not have any such plans in place and might not even know very basic things like if a substitute decision maker is required, who is that person and how does one get a hold of them, and are they aware of the person's goals and values? It's needed during the pandemic because these are the sorts of decisions that will be required if somebody actually becomes quite ill and is admitted to hospital and is unable at that time to participate in decision making. And basically it uses this supported decision making approach that I've just been talking about. So that's all I have to say. And I'm really happy to have time to open this up now for discussion. I guess just in conclusion, what I've tried to, maybe just go to the last slide. I just tried to highlight what a capabilities approach involves and why it's important and also challenging, and that's in the context of ableism, and how one might get started. And there are a couple tools that are suggested, and there are a couple clinics that could also help with facilitating this process. Thank you very much.
Thanks so much, Dr. Sullivan. And as I said, even as you were going through that, there's just so much new thought that I think, at least personally, I need to put into this. You know, I was thinking, preparing for today, just the incredible wealth of knowledge that we as caregivers have about our sons or daughters. You know, we know the history, especially as, you know, there's this transition from pediatrics to adult supports, and the whole system changes for us, navigating a new system at the time of transition. And but how we hold all of that history, we can share strategies that calm our loved one. We can talk about preferences and sensitivities that can help make things, you know, go much better. You know, triggering words or actions that might get in the way of, you know, their health care, how much they're understanding in the moment and how much needs to be taken back home and gone over multiple times to, you know, maybe with visuals to help with further understanding. And I was just thinking about how, as we hold all of this information and how we've been advocating for years and years in school or other settings, healthcare settings, as when they were younger, how it's the challenge now for me, speaking personally, to bring, and I want to do this, and I really hear this when I'm listening to you, Dr. Sullivan and Audrey, is to really, how do I more empower my loved one's voice, so that even though I carry all this information and hold all of it, the very, very important importance of including their voice. And also, I just was, when reflecting about today, just thinking about, by the time our kids are adults, we as caregivers are often feeling a lot of fatigue. And so again, it's so important not to feel like, oh man, this is something else I need to do, or this is something else I need to do alone. But I really appreciated the fact that we need to bring supports around us to include our loved one's voice, and to include others' voices that know our loved one well. And I think COVID really highlighted that for me in terms of my own vulnerability and the vulnerability of my loved one. And so I just really appreciate today's topic, and I really want to hear from the questions from our audience about, thinking of this. This isn't something we can do quickly. It's something, though, that there's some forms in place, like that form that you just talked to us about, the advanced care planning and in response to COVID, that can start us thinking about and recording this vital information in writing in a place that can be accessed when our loved one needs it, like a suitcase at the door. It's ready to go, so that if anything should happen to us, or if our loved one needed attention quickly, and I think that's what COVID really highlighted for me, is that I need to take steps towards this, and no matter how overwhelming it might feel, just start moving in this direction of empowering my son's voice and recording it, and having these conversations and getting them down in written format. So yeah, that's kind of, I'd love to hear if there's any questions from our audience, or from Dr. Lunsky or Audrey, if you've got other thoughts about it as well.
I think, quickly, Lee, it's a great segue, and we purposely did this. We can talk for hours about this, and in fact, when we were planning, we did talk for hours about it. But it is an opportunity for everyone listening to put their questions into the chat box, so we can do our best to read out some of them and try to respond to them. It is something I think we all kind of avoid thinking about, and it's just not sort of common practice, I think, which is why we want to introduce some of these ideas and this process, which I think, to re-emphasize, Lee, is a gradual process, and also, one that is really not, it's all, the term supported decision-making, it's reminding me, it's not so much that I'm supporting my sister or my brother or my child, but I also need support. So it's a real group effort, I think, to help make that decision, to help people with making decisions about their health care.
I really agree with you, Yona. I think it's about thinking about who could be part of the team, but putting our loved one in the center of the team, that their voice, it's a real challenge for me after years of advocating, not to just keep hearing my own voice speaking on behalf of Eric. How do I listen to him, hear him, record it, make sure that it's in a place where his voice is front and center? And then I'm thinking, well, don't go automatically, well, my son is, a daughter's nonverbal or something. We know, no matter what, that they have ways of expressing their needs and wants and desires. And it takes creativity sometimes to have other people understand that. But we hold that, but if something should happen to me tomorrow, do other people know what I know? And how do other people know how to bring that out and get that information? So yeah, I guess I just found today's topic really challenging for me, because I know I can't do this alone. And I don't feel, I didn't want anybody to walk away from this webinar going, oh man, did I ever drop the ball on this? Now where do I start? I just wanted to start the conversation because people like Audrey, who've been doing this for years and years, we can learn from, you know, what the fairness of what substitute decision making is. I mean, the unfairness of that and how other people are deciding on behalf of our loved ones. But anyway, just wanted to hear from those who are in attendance, I guess.
So I've typed a couple questions in the chat box. Someone would like to know, what do people find particularly challenging and what are some of the barriers to planning ahead? And, you know, of all the difficult things, what do they specifically find difficult?
Bill Sullivan, I'll give a little stab at that. You know, I must say that this is, what we're talking about is a culture shift on many levels. And given that, there's not a lot of experience in doing this. So that's sort of, we're not kind of talking about something that in Ontario, there's a lot of experience with and knowledge of, you know, what works best yet. But that's the sort of thing that is really needed. One of the things that I would highlight is that just thinking about advanced care planning in the context of COVID, that this won't happen spontaneously, right? To bring a team together and talk about these difficult issues in a sensitive way won't just happen. You know, there has to be, you know, people that kind of find who is on the team and maybe somebody designated to coordinate things so that, because really these days, these conversations would need to be done virtually because people are unlikely going to be meeting in person to do this planning. And so just to say that that's one of the roles that currently nobody is designated as a coordinator for supported decision making. And so it's, some of this has to be, there has to just be creativity, like finding who's involved and who can do what on the team.
Bill, there's, I guess, somewhat of a follow-up question. Someone wants to know what we need to do to make supported decision-making recognized in the law. Is there anything happening on the legal side?
Very good question. So just so that people don't think this is a really way out left field idea, this is actually part of the Convention on the Rights of People with Disabilities that Canada has signed up to. And so what we're in the process of doing is trying to practically promote this approach in practice. And there are a number of places in Canada where this is already part of legislation. What makes it more difficult are those places in Canada where it's not yet part of legislation. Now, one thing about these two tools that I mentioned is that they are compatible with the current law. And so this approach can be undertaken within the, the constraints of the current law. Yeah, so the other thing that people should know is that already in Ontario, the Human Rights Commission indicates that healthcare providers must provide reasonable accommodations in healthcare, and that's essentially what we're talking about. A person is a type of accommodation.
Thank you, Bill. We have a question about suggestions for nonverbal individuals who can't advocate for themselves, and perhaps another question that's related in terms of what to do when someone, the person you support, doesn't want you involved or doesn't want to accept that support.
Now, maybe Audrey would be the person to speak about the nonverbal person, because that's her experience. I can also speak a little bit about if the person does not want the support. So basically what we're proposing might not work for everybody, right? People can opt out, but it may be that just needs to be explored a bit, and that really it might be part of a history of them, just being ignored, and they just are fed up with it. So, so that's something to explore for sure.
This Audrey here. I'm not much use to any of you on the issue of people who would argue with a son or a daughter who would argue. I have no experience of that. My son is spoken and has a profound intellectual disability, and that's where my experience is. So I'm not very helpful on the practical, how do you deal with it when the person doesn't agree. I don't know, because I don't have that kind of experience.
There was a question around our nonverbal, what should be done in those situations. So what maybe you can share insight or advice around that?
Well, if indeed, I think we should all from the beginning work on our medical people, because they're the ones the most likely to be involved in these kinds of difficulties. And I think it's really important for families to develop a relationship with their medical caregivers, so that they do understand the legal capacity under current law, as Bill has said, it includes supported decision making. It's just that they've never heard of it because they don't teach it in medical school. I know that, but we have to do that teaching, and get to know, make sure our medical caregivers do understand and do relate in an appropriate way to our sons and daughters. And that might be harder for people with sons and daughters who can speak and argue. It's not been difficult for us in our family, because Ian doesn't. He doesn't resist. He knows what he likes and what he doesn't like, and he will resist. But he can't do that with respect to a discussion, because he doesn't understand sufficient words to understand a debate. I'm not really an awful lot of help to you on this, because my experience, although it's been a long experience, it's been very limited to people who can't communicate in ways that most people would be able to interpret or understand.
Just add to that, I think one thing I'm taking from this is how different everybody is that we're thinking about. And so again, this idea of supported decision making and planning is really, it's so individualized. And Audrey, because you know Ian so well, and the people who support him in his home also do, what his preferences are, and you can help sort of modeling and doing that teaching, with the medical providers on that, and how you understand that, and how you where's the evidence that makes you know what it is that's important for Ian. So that's the kind of stuff you just know from experience, and you can kind of teach that. And I would argue reteach that, because we teach the physician, and then we get a new physician when we go to the emergency department that doesn't know any of it, and we have to teach it again, and manage our frustration, I think, when we're doing so. But in terms of the question about when the person maybe doesn't agree, Bill, you talked about this idea that it's helpful to understand maybe what it is that they don't agree to. And it's what a learning opportunity, first of all, what an opportunity to respect their autonomy and their voice, that they want to be able to make that decision. right? And how do we support that and support that decision and understand it, you know, in a way that's not necessarily putting them at risk, but is empowering them and teaching them. And it may be that there's something we can learn, like you said, Bill, about why it is that they don't want someone else involved, or what that means about them as a person if they can't make that decision. You know, why is that such a threatening thing? You know, and is there someone that they, because a lot of us, you know, with or without a disability, if I have a healthcare issue right now and it's a big issue, there's certain things that I'm going to actually want to bring other people in on to help me make my decision, right? If I'm going to, you know, put a bandage on my cut, I don't need too many people to help me with that. But if I'm deciding on what kind of treatment I want for cancer, you know, or when I want palliative care versus when I want something more invasive, I don't make that decision on my own. So I think helping people with disabilities to understand why sometimes it is helpful to have some help, and what would be helpful and who is helpful, and helping them play a role in making those decisions, that actually someone who says, I want to do this on my own, may actually decide, actually, that's a big decision. Maybe there are people I could think about it with, but I'd like it to be in this way and not in that way. You know, so I think there's so much we can learn, and not to sort of make quick decisions in this regard, and to figure out how we have teams. I think, Audrey, you mentioned, you know, the importance of that relationship you have with the primary care provider. If there's a strong relationship going there, and we're recognizing, and it's in our guidelines, Bill, you know, about the importance of including that circle of care and making decisions, why that's a good way for us to do our work. If that's really part of what we're doing in our regular interactions that are in emergencies with the healthcare providers who know us best, I think it will allow supported decision making to happen more naturally with more people.
Yeah. We have to be very careful when we're talking about this to people, to professional people with who are not familiar with it. It can so easily be misconstrued. We had an appalling situation in the family just a few weeks ago. My son was in a life-threatening situation. He had brain hemorrhages, and in being asked what we would want in you know, depending on his situation, he was virtually at death's door at one point. There was a complete misunderstanding, because I spoke about Ian, what was best for Ian, and the assumption that was made from just one little statement I made in the middle of the sentence was that I was actually more or less giving them a DNR, and the nurse told Ian staff that had been my decision, that there would be, you know, no treatment if things went bad. We had to transfer him to another hospital, and I was horrified, because that was just the opposite of what I'd been saying. But you see, I see my son as having value and having respect. But obviously, the person I was speaking to saw him just as a person with a disability who couldn't speak, and obviously was not giving him that kind of respect. And it completely changed what she thought I said. So it's very easy to be misunderstood when people can't communicate themselves. That was just a sideline, but it was a very scary one.
Thank you, Audrey, for that story.
That's really important what you said, Audrey, and thank you for sharing that personal example, because you just pointed out that how clear we need to be, and I think that's why not this idea of capturing some of this very important information in written form, so that in a case like that, the person's bias clouded what you actually were saying. So that's something else we need to be aware of, and the importance of, I guess, I really feel starting some of these really important conversations now. There's one question here that Dr. Sullivan, if you could talk about, what's the difference between power of attorney and substitute decision making, and what needs to be put in place to enable supported decision making? you know, it's somewhat confusing for sure.
Yes, very good question. I think when we're talking about a substitute decision maker, that is a power of attorney. Now, a power of attorney can be for more than just health care. But in this context, we're talking about the substitute decision maker who would be involved in helping with healthcare decisions. In the advanced care planning tool, there's a lot of detail about that, who that person is, and even the option that you know, people should know that everybody in the province automatically has a substitute decision maker, and it's according to a hierarchy. But if people don't want somebody else in that role, there's a way of doing that, and that's outlined in the tool. So the other question was, how do we support a supported decision-making approach? And I think it's things that have just been talked about. For instance, Audrey's comment was, she was actually, I would say, functioning in that role. She's sort of interpreting Ian's goals and values and applying them to this decision. And I think it is important in the context of COVID that there not be this assumption that just because somebody has a disability, that means do not resuscitate. And that's a very important healthcare decision that this advanced care planning will help people to think carefully about before confronted with a very complex situation that where decisions might have to be made rather quickly.
Thank you so much. That really helps me understand that power of attorney and substitute decision making are really, we're talking about the same thing.
The difference really is that you choose, in a power of attorney, you're choosing your guardian. They don't use the term guardian in power of attorney law, but power of attorney law is part of the Substitute Decisions Act. Powers of attorney are substitute decision processes, but you choose. You have the right to choose what will be decided and what won't be decided, and who will do that.
Thanks, Audrey. I guess just, I know our time is running out, and I guess the main thing that I was worried about, you know, in terms of, just because this comes up for me, is like, oh boy, now what do I do? Can we just end with parents and caregivers and siblings, you know, just like, what do we do when we leave this webinar? What's the next step you recommend we should take?
I think there are a lot of next steps. I think that we need to tell each other about this. There's not a big system. There used to be years and years ago in the association, for example. Families got together and talked about these kinds of issues. We don't get that kind of opportunity as much as in these days. The system has changed, and I think it's absolutely critical that parents are talking about this, because we're all in the same boat here. And we don't get much warning. We didn't get any warning when Ian's brain started to bleed. You don't get warning of these things. You need to make these decisions, or have somebody able to make decisions, or support the person in making decisions, or knowing what the person's wish would be, were they able to express it. We have to put that in place. And nobody can do that for us. We have to do that.
Right.
And I think we should all be concentrating on this. And it's something that I've been told rarely gets. I've been living it for so long. It's almost in my mind. But I'm told that for most families, it's not an issue until the crisis arrives, and it's probably too late then.
Right. Bill Sullivan here. I would totally agree with everything Audrey says or just said. I would also alert people that you might be a good advocate by letting your healthcare professional, your family doctor, know about the decision-making tool, because they might not be aware of that. And also just to know that families can receive support. So I mentioned a couple clinics that we're involved in where these issues are explored. We're hoping that this becomes much more general, so that especially during these times of transition, there's more help from the medical world that provides a space for such discussions.
Thanks so much. We're out of time. I realize that there's just so many important things that were said today, and we'll try to, I know we'll capture this in our resources that will go out to all of you who participated today. So I'll give Dr. Lunsky the last word.
Just to thank you, Lee, for pushing us to reach out to you, Bill, and to you, Audrey. Thank you, everyone, for giving your time to this really important topic. We're not done yet, but I think in terms of that first step, maybe this was the first step, everyone, just having this virtual conversation now, doing some reading, reaching out to your primary care provider and your family, and also reaching out to one another. So we'll be sending soon, as well as a survey on how you found things today. We know the technology wasn't perfect, but thank you for hanging in with us anyways. And take care of yourselves in this heat. And we'll see you soon.
Bye.
Bye.
Bye, thank you.